नमस्कार दोस्तों। तो आज हम स्टार्ट करते हैं अप्रोच टू पैराप्लेजिया और पैरापेरेसिस। बेसिकली अप्रोच टू पैरापेरेसिस और पैराप्लेजिया इज ए कॉमन केस given in the exam either for the MBBS exam, MD medicine exam or the DM exam. In MBBS exam and in MD medicine exam, paraplegia or paraparesis come as a long case for total discussion. In DM neurology exam, paraparesis is a small case. तो विदाउट डिले मैं सौरभ गुप्ता स्टार्ट करते हैं आज का टॉपिक अप्रोच टू पैराप्लेजिया लॉन्ग क्लिनिक 3। So what is paraplegia या paraparesis? Paraplegia is the complete weakness of the both lower limb. So if weakness of the both lower limb is there, if complete weakness is there, then we call as the paraplegia. If partial weakness or incomplete weakness of the both lower limb, then we call it as a paraparesis. So paraplegia and the paraparesis is the weakness of the both lower limb. So as we discussed in previous cases like approach to hemiparesis or general approach in neurology case, we always say कि when we approach, there are three questions in our mind: where is the lesion, what is the lesion, and why is the lesion occur. So first is the where is the lesion occur, from where. So if we approach a case of paraparesis, so lesion may be anywhere from brain to the muscles. So if we discuss about the brain, this is the cortex, this is the opposite side of cortex, this is the brain stem. After brain stem, this is the spinal cord. So if we discuss the location of the cerebral cortex, motor fiber located out here, lower limb area is here, then the upper limb or trunk. From lower limb, from cortex, fiber goes through coronary data, then internal capsule, then descend in the brainstem, and at the level of lower medulla, cortico-spinal fiber decussate and reaches to the opposite side of the spinal cord. After that, enter horn cell in the spinal cord, roots. Multiple roots form the plexus like brachial plexus and the lumbosacral plexus, then nerve, then neuromuscular junction and the muscles. So lesion from anywhere from the brain cortex, brain stem, spinal cord, anterior horn cell, root, plexus, nerves, neuromuscular junction and muscles. So any lesion started from the brain cortex, brainstem, upper spinal cord, lower spinal cord, anterior horn cell, root, plexus, nerves, neuromuscular junction and muscles can causes weakness of the lower limb. But few places like brain cortex, spinal cord below T1 level, nerve involvement neuropathy and the muscle involvement myopathy gives the classical presentation of the lower limb weakness or paraplegia or the paraparesis. Brainstem and spinal cord above T1 usually present as a quadriparesis. So any lesion in the brainstem may cause hemiparesis or quadriparesis. Any lesion above T1 in the spinal cord causes usually quadriparesis. Plexus usually does not causes bilateral weakness, usually causes the unilateral weakness or weakness in the only one side of the one lower limb, either involvement of lumbar plus sacral plexus. If involved in the brachial plexus, weakness in the only one upper limb. NMJ usually causes pure motor weakness, fatigability, other criteria are also there. So muscle weakness, myopathies, nerve weakness, neuropathies, spinal cord involvement below T1 level, and cortical lesion usually a cause of the paraparesis or the paraplegia. So again, cortex, corticospinal fibers, these are the area of the lower limbs. So this is the cortical area, which is the around parasagittal area. This is the area for the legs. So involvement of this area in the cortex may causes weakness in the both lower limb. After this, fibers goes down and medulla, at the level of medulla, decussate to the opposite side, and above T1. If weakness is above T1, so it causes usually quadriparesis, I say, because C4 to T1 is the fiber that form the brachial plexus and supplies the upper limb, and below T1 supplies the lower limb and the trunk. So any lesion below T1 in the spinal cord causes classical paraparesis or the paraplegia. In brain cortex, involvement of the bilateral parasagittal area can causes the weakness of the both lower limb. As I say, neuropathy and the myopathy again may causes the weakness of the both lower limb or the paraparesis. So before going to this, I also discussed some fibers. So basically, if we discuss the paraparesis, we have mainly three type of tracts. One is the pyramidal tract, second is the spinothalamic tract, and third is the posterior column. So if we discuss the paraparesis or we localize the lesion, those three tracts should be kept in the mind. Pyramidal tract, also called as corticospinal tract, corticospinal tract. Spinothalamic tract, which have two types, lateral and the anterior, and posterior column. Corticospinal tract are the descending tract. Corticospinal tract are the descending tract, and spinothalamic and the posterior column are the ascending tract. So if we discuss further corticospinal tract arises from the cortex, descend corona radiata, internal capsule, and at the level of medulla they decussate and give supplies. If this is the left brain, this controls the right leg. If we discuss the paraparesis, so left brain controls the right side of the leg. So this is the corticospinal tract or descending tract. Second is the spinothalamic tract. Spinothalamic tract are the sensory tract. If this is arises from the right leg, goes to the spinal cord, and their fiber crosses the spinal cord just near the level of the nerve. So this fiber crosses the spinal cord at the same level and goes up, reaches to the thalamus and then the sensory cortex. So spinothalamic tract crosses the midline at the level of spinal cord, reaches the thalamus and the cortex. This is called as the spinothalamic tract. Then posterior column. Posterior column if posterior column from the right leg goes up and crosses the midline at the level of medulla and goes to the brain. So descending tract, corticospinal tract arises from the brain, decussate at the medulla and supplies the right side of the body if fiber on the left side. Corticospinal tract, then spinothalamic tract, right leg spinothalamic tract, cross midline at the level of spinal cord, reaches up, supplies to the thalamus, goes to the thalamus and the cortex, and dorsal column also decussate at the level of our medulla. So if we discuss at the spinal level, so at the spinal level our corticospinal tract and the posterior column are on the same side, affected on the same side, and spinothalamic tract of the opposite side. And for the lesion, if in the cortex, if pyramidal tract and the dorsal column supplies to the opposite side, here fiber from the opposite side, and corticospinal tract on the spinothalamic tract on the same side. So spinothalamic tract decussate at the level of spinal cord, but our pyramidal tract decussate at the level of medulla. Basically this is also necessary when we discuss the level of the spinal cord in the paraparesis approach. So as we started, lesion from cortex to the muscle anyway can cause the paraparesis. So now we discuss the cortex or the brain lesion, how it causes the paraparesis. So cortex of the brain may cause paraparesis. Clinical features, what clinical features is there? Weakness of the both lower limb, as we say the paraparesis. Sensory sparing, because sensory fiber usually not involved in case of cortical type of paraparesis. If there is a large lesion, they may cause the sensory involvement. Early bladder bowel involvement is there, and other cortical feature like headache or seizure may be present. Causes are like the single ACA, anterior cerebral artery thrombosis, or superior sagittal sinus thrombosis, and the parasagittal meningioma. So this is the homunculus or pyramidal tract. So we see leg is in the area of the parasagittal region. This is the area of leg. So if there is a involvement of bilateral this area, it causes paraparesis of cortex causes. And nearby this area is also the area of the bladder involvement. So early bladder involvement seen in the cortical region of the paraparesis. Other than this, so what are the causes for this reason? We have the anterior cerebral artery which is bilateral. If there is a single anterior cerebral artery and it will be thrombosed, it causes involvement of the both side of the ACA region, like both side of the parasagittal region, and it may causes the paraparesis. Any thrombosis of the superior sagittal sinus may causes involvement of this area and may causes the paraparesis. Any meningioma, parasagittal meningioma in this region may causes paraparesis of the cortical cause. As I discussed, fiber goes down through coronary artery, internal capsule, midbrain, pons, medulla at the level of lower medulla, crosses to the opposite side and supplies the lower limb and the upper limb. So corticospinal tract crosses at the medulla and supplies the opposite side. So after the cortical lesion, paraparesis may be due to the brainstem lesion, upper cervical cord lesion. As I discussed, these both area usually does not causes paraparesis, may sometimes maybe paraparesis, but it progress to the cortiparesis. So we don't go detail of the brainstem and the upper cervical cord, because this area does not causes classical paraparesis. Spinal cord level below T1, this is the classical paraparesis. And in exam case also, usually thoracic region cases like Pott's spine, like to transverse myelitis, like hereditary spastic paraparesis, these cases usually kept as a long case or the short case in the exam. And spinal cord level for the paraparesis we discuss in the details. Anterior horn cell lesion, roots may sometimes causes the paraparesis. Plexus, I say, usually does not causes paraparesis, usually causes the monoparesis or the weakness in the bone. Nerves lesion like neuropathy, muscles, myopathy, they may causes the paraparesis. In nerves, we usually may get the case of the GBS or the diabetic neuropathy for the long case or the short case. So if we discuss the paraplegia, classical paraplegia, so we divide in two groups, either flaccid paraparesis or the spastic paraparesis. Spastic paraparesis means UM lesion, upper motor neuron lesion. So as we see, brainstem, brain, spinal cord are the upper motor neuron side. Lesion in the spinal cord, brainstem and the brain causes the UMN type of paraparesis or the spastic paraplegia paraparesis. Lesion after the spinal cord, involvement of the anterior horn cell, involvement of the neuromuscular junction, nerves, plexus and the muscles causes the element type of paraparesis or the flaccid type of paraparesis. So paraplegia or paraparesis of two types, spastic and the flaccid. In spastic, there are two main causes, brain and the spinal cord. As I say, upper spinal cord or the brainstem usually does not causes paraparesis. In brain, stroke, bilateral median temporal lobe, bilateral frontal lobe, this is the cortex, this area is involved. Multiple sclerosis, cerebral palsy, brain tumor like parasagittal meningioma may causes paraparesis of the brain. Spinal cord injuries, transverse myelitis, spinal tumor, cervical or thoracic. This section we will discuss in the detail. In flaccid type of paraparesis, involvement may be the spinal cord, especially the acute spinal shock stage in the early phase. So spinal cord lesion may causes flaccid type of paralysis when there is a early history. In acute phase, there is a phase of the spinal shock in which, despite involvement of the spinal cord, we get the flaccid type of weakness, we get the element sign in the lower limb. Anterior horn cell disease like polio and the SMA may causes the paraparesis. In neuropathy, GBS, diabetic neuropathy, peripheral injury and the leprosy. In myopathy, muscular dystrophy, polymyositis, hypokalemic periodic paralysis and the myasthenia gravis is a type of neuromuscular junction disorder. So in paraplegia, we divide spastic and the flaccid. So if we differentiate in both spastic paraplegia and the flaccid paraplegia, spastic paraplegia means the spasticity is there, flaccid is the flaccidity is there. So if we discuss where is the lesion, in spastic paraplegia, upper motor type of lesion is there. In flaccid, there is a lesion in the lower motor neuron. Tone is increased in the spastic, as the word says, spasticity. So UMS sign is there. So we get the increased tone, we get the hyperreflexia, we get the extensor plantar. These all are the UMN sign. And clonus is there. So increased tone, hyperreflexia, plantar extensor and the clonus are the sign of the UMN type of lesion which is in the spastic paraplegia. In flaccid paraplegia, there is a tone decrease or absent, hyporeflexia or areflexia, plantar or flexor or absent and clonus is absent. So we get the element type of features. So if there is a neuropathy, myopathy, anterior horn cell disease, root, plexus, so we get the element sign. If there is a lesion in the spinal cord or the brain or brainstem, we got the UMN type of the sign and the spastic paraplegia. Atrophy is usually seen in the element type of lesion seen in the flaccid paralysis. In spastic paraplegia, atrophy is usually late or maybe the disuse atrophy. Fasciculation. Fasciculation is a feature of element type of lesion, especially the anterior horn cell disease. In spastic paraplegia, fasciculation is absent. Bladder involvement. Bladder involvement in spastic paraplegia is the spastic type of bladder, and in flaccid paraplegia there is a atonic type of bladder. Typical causes like myelopathy or the hereditary spastic paraplegia. Causes of the flaccid paralysis are the GBS and the cauda equina syndrome. Gait, we get the spastic gait or the scissoring gait. In we get the floppy or the weak gait. Usually flaccid paraplegia have more weakness, more pronounced weakness as compared to spastic paraplegia. Like hereditary spastic paraplegia, we get the scissoring gait. Patient is able to walk but scissoring. In case of element type weakness, patient is usually unable to walk. Superficial reflex usually lost in both element and the human types. Clinical clues is the stiff leg and the floppy legs. यानी कि legs ऐसे पड़ी होंगी, उसमें leg एकदम stiff होंगी. Exception are the spinal shock initially causes flaccid paralysis. I will discuss acute spinal cord lesion like myelitis may causes acute spinal shock stage में flaccid paralysis देखने को मिल सकता है. तो ये बात होगी spastic paraplegia and the flaccid paraplegia, यानी कि element type of paraplegia and the UMN type of paraplegia. So if we get any case, so for approach we should know where is the lesion, like from brain to muscle, anywhere can be the lesion, like brain stem, spinal cord above T1, spinal cord, anterior horn cell, root, plexus, nerves, muscles, neuromuscular junction. So anywhere is the lesion. What type of lesion? Maybe flaccid type of paralysis or the spastic type of paraplegia or paraparesis. Now we come to the spinal cord level. When we get the spinal cord case, so there are few things should be in our mind. First, there is a what is the motor level, what is the sensory level, and what is the reflex level. So for spinal cord case, we should localize our case according to motor level, sensory level, and the reflex level, because all three level should be around same level to make a proper diagnosis, a proper etiological diagnosis or proper localization diagnosis. So now we discuss the spinal cord disorders. Spinal cord disorders, like if we say, first we classify the paraplegia and the spastic paraplegia and the flaccid paraplegia. In spastic paraplegia, we have two types of compressive myelopathy and the non-compressive myelopathy. Compressive myelopathy may be the intramedullary, extramedullary. In intramedullary, may be the intradural and the extradural. Basically, so this is the diagram of the spinal cord. This is the spinal cord. This is the vertebra. So this is the cut section of the vertebra and the spinal cord. So this is the spinal cord. This is our nerves, nerve root. This is the substances of the canal. This is the central canal, and this is the substance of the spinal cord. So this is layer is the dura mater. This is the dura mater. This is the arachnoid mater. So any lesion outside the dura mater is called as the extramedullary extradural lesion. So any lesion outside the dura mater is the extramedullary extradural lesion. Any lesion which is beneath the dura mater and outside the medulla, यानी कि spinal cord, is the extramedullary intradural lesion. This is the extramedullary intradural lesion. This is the dura is the outside of the lesion. So if dura mater is inside the lesion, this is the extradural extramedullary lesion. If dura mater is above the lesion, this is the intradural extramedullary lesion. If lesion is the spinal cord parenchyma, this is called as the intramedullary lesion. So for compressive myelopathy, we divide lesion in the three groups: extramedullary extradural outside the dura mater, extramedullary intradural inside the dura mater but outside the medulla, And if there is a lesion in the parenchyma of the spinal cord, it is called as the intramedullary type of lesion. So for compressive lesion, we classify in 3 groups: extramedullary extradural, extramedullary intradural, and the intramedullary lesion, according to the place where is the lesion is located, because this is help in the approach and the making the diagnosis. So for compressive, intramedullary lesion and extramedullary, in intramedullary, intradural, and the extradural lesion is there. In intramedullary, there is maybe ependymoma, glioma, syringomyelia, and the hematomyelia. In intradural lesion, we have meningioma and the neurofibroma. For extra medullary, we have fracture, epidural abscess, Pott's spine, and the metastasis. Basically, for extradural lesion, we have, this is the extradural region. So may come from the bone, maybe due to the Pott's spine, may come to the nearby muscles that may be the epidural abscess in this place, Pott's spine, and metastasis in the spine may causes the extramedullary extradural lesion. So this is the compressive. In non-compressive, we have many lesions like motor neuron disease, subacute combined degeneration, multiple sclerosis, vascular lesion. For MND is the involvement of the anterior horn cell, in which we have both type of features, UMN type and the element type. Subacute combined degeneration, mainly involvement of the posterior cord due to vitamin B12 deficiency. Multiple sclerosis, the demyelinating disorder, vascular lesion, anterior spinal artery thrombosis or the posterior spinal artery thrombosis. Letharism is the caused by the consumption of the keshri dal. It is the toxin-induced disease. Familial spastic paraplegia is the weakness of the both limb with the genetic cause. Friedreich ataxia, in which we have the weakness of the both lower limb associated with the cerebellar ataxia. Transverse myelitis, again involvement of the spinal cord due to the inflammation. This may be post-viral infection or post-inflammatory, may be the transverse myelitis. Now this is the important diagram. As initially we discussed the tracts in the spinal cord, ascending tract and the descending tract. For ascending tract, we have main posterior column is the ascending tract, in which fasciculus cuneatus and the fasciculus gracilis, joint position, vibration, and the pressure sense carried by the posterior column. These are the ascending tract. As we discussed, कि posterior column decussate at the level of medulla. So in spinal cord lesion, involvement of the posterior column on the same side of the limb. This is the lateral spinothalamic tract, which govern the pain and the temperature. CT. This is the ventral spinothalamic tract for the pressure and the touch, and the corticospinal tract. So this is the descending tract. And posterior column and the lateral spinothalamic, these are the ascending tract. So for paraparesis point of view, there are 3 tracts which should be kept in the mind: lateral corticospinal tract or pyramidal tract. These are the descending tract, arise from the cortex and goes to the spinal cord down, and sacral fiber outside, then lumbar fiber, then thoracic fiber, then the cervical fiber. So position of the fibers: sacral, lumbar, thoracic, and the cervical, outside to in. Lateral spinothalamic tract and ventral spinothalamic, these are the ascending tract. Fibers are the sacral outside and the cervical fiber inside. For posterior column lesion, sacral fiber inside around the midline and cervical fiber outside, and these fiber crosses at the level of medulla. These fiber also crosses at the level of medulla, but lateral spinothalamic tract crosses midline at the same level of the spinal cord. So if there is an involvement of the central canal, then in this type of lesion also pain and temperature sensation is involved. Other sensation is spared. This is called a dissociative type of anesthesia. So corticospinal tract, posterior column, and the lateral spinothalamic tract are main track for the paraparesis point of view. This we discussed type of lesions. So this again we have compressive myelopathy. There are three type of lesions: extramedullary extradural, extramedullary intradural, and the intramedullary. So this is the differentiating features of the all these three. First is the onset. Extramedullary extradural usually rapid onset because there is a compression from outside. Extramedullary intradural usually slow progressive, and intramedullary usually slow or maybe rapid in some cases. Spinal tenderness is present in extramedullary lesion because involvement of the vertebral bone also. So if we see the tenderness is present in the extramedullary extradural lesion, rare in the extramedullary intradural, and absent in the intramedullary lesion. Root pain also a features of the extramedullary extradural. So because these lesions are extradural, they may causes the compression of the root, and that may causes the root pain. So root pain, spinal tenderness are features of the extramedullary extradural lesion, and these are uncommon and the absent in the intramedullary type of lesion. Position sense, early loss, because here is the fiber of the posterior column, so involvement is early, posterior column loss early, may be lost, but spare in the intramedullary. If lesion is the intramedullary, there is a sparing of the posterior column. So sparing of the posterior column seen in the intramedullary type of lesion. Pain and temperature loss in the all types of lesion, because pain and temperature fiber crosses the midline from one side to the other side, so they may be involved in the all type of disorders. Sacral loss is early seen and sacral sparing. As we discussed in the previous slide, sacral fiber outside. So if there is a lesion from the outside like extramedullary extradural, sacral fiber involved first, but in central canal lesion or intramedullary lesion, sacral fiber usually involved late or maybe spared in the early cases. So sacral sparing seen in the intramedullary type of lesion because sacral fiber are the more outside fiber, so spared in the intramedullary type of lesion. Bladder vowel involvement seen in the early because bladder vowel fiber around the central cord. So intramedullary lesion causes early bladder vowel involvement, and other may bladder vowel involvement is late. So for compressive myelopathy, compressive spinal myelopathy, extramedullary extradural, extramedullary intradural, and the intramedullary. So in extramedullary extradural, root pain, spinal tenderness is there, root pain is there, and onset is usually rapid. Onset is usually comparatively slow. Position sense loss early, involvement of the posterior column, pain temperature loss in all three, sacral sparing seen in the intramedullary region, and the bladder vowel involvement early seen in the intramedullary region. So intramedullary region में sacral sparing because sacral fiber is outside, early bladder vowel involvement is there in the intramedullary region. So this is the differentiating features of the extramedullary extradural, extramedullary intradural, and the intramedullary lesions of the compressive myelopathy. Then we come to the spinal cord syndrome. Basically, as we discuss, this is the spinal cord. So we have corticospinal tract, we have lateral spinothalamic tract, we have the posterior column. So various type of spinal cord syndrome like Hemi cord syndrome or Brown's cord syndrome, in which there is a involvement of the one half of the spinal cord, Brown's cord syndrome. So in this, as we discussed, corticospinal tract and the pyramidal and the posterior column are affected on the same side. So if this is the left side, involvement of the spinal cord, so it will cause the weakness of left leg, joint position, vibration on left leg, but because lateral spinothalamic tract crosses midline and reaches to the opposite side, so pain and temperature on opposite side. So in hemichord lesion or Brown-Sequard syndrome, we get weakness of the one side of the body with involvement of the joint position, vibration, pressure sense on the same one side of body, but involvement of the pain and temperature on the opposite side. This is the classical hemichord syndrome or the Brown-Sequard syndrome. So again, discuss the anterior cord syndrome. So if there is an involvement of the anterior cord, which is seen in the this is the posterior column, this is the lateral corticospinal tract, this is the lateral spinothalamic tract. So if there is a lesion in the anterior cord which is seen due to the anterior spinal artery thrombosis, this will causes involvement of the both lower limb and it will cause the weakness of both lower limb, with loss of pain and temperature of both side, but sparing of the posterior column. So in anterior cord syndrome, involvement of the anterior spinal artery thrombosis, which is a vascular phenomena, acute onset phenomena, sudden onset phenomena, in which there is a weakness of the both lower limb associated with the pain and temperature loss in the both lower limb, but sparing of the posterior cord column. This is the classical feature of the anterior cord syndrome. In posterior cord syndrome, which is maybe due to the posterior spinal cord thrombosis or maybe seeing the subacute combined degeneration due to the vitamin B12 deficiency, it mainly involves the posterior column. So in posterior cord syndrome, there is an involvement of the posterior column which causes the loss of joint position, vibration sense in the lower limb, but sparing of the motor weakness or sparing of the pain and temperature in the lower limb. So this is the example of the posterior cord syndrome. Then the central cord syndrome. In central cord syndrome, there is involved the central cord. So it causes the dissociative type of anesthesia, because in this, as lateral spinothalamic tract fiber crosses midline through the central canal, near central canal, so involvement of the pain and temperature fiber is there. So loss of pain and temperature fiber is there, but sparing of the posterior column, and early bladder wobble involvement seen in the central cord syndrome. So in hemichord syndrome, Brown-Sequard syndrome, loss of weakness of one side, involve the posterior column on one side and pain and temperature on the other side. In anterior cord lesion, sparing of the posterior column. In posterior cord syndrome, sparing of the anterior pain and temperature and the weakness. In central cord syndrome, there is a dissociative anesthesia and early bladder wobble involvement is seen. So we discussed about the compressive myelopathy. Now how to differentiate between the compressive and the non-compressive myelopathy. myelopathy. So in compressive myelopathy, root pain, bony deformity and bony tenderness, girdle-like sensation are the features of the compressive myelopathy, because due to the compression from outside or inside to the out, it causes the involvement of the root, which causes the root pain. In non-compressive, there is a no root pain. Bony deformity due to the involvement of the spinal canal or due to the involvement of the bone of the spine, in Pott's spine, in metastasis, in fracture, in abscess, they causes bony deformity. So bony tenderness is also there, and girdle-like sensation, like feeling of the someone या some रस्सी like कुछ टाइप बाइंडिंग है किसी thorax के आसपास, girdle-like sensation are the seen in the compressive type of myelopathy. So these root pain, bony tenderness, bony deformity, girdle-like sensation, and upper level of sensory loss, clear level of sensory loss seen in the compressive type of myelopathy and not present in the non-compressive type of myelopathy. Onset, usually compressive myelopathy onset is gradual. In non-compressive, maybe acute, maybe gradual. Like acute transverse myelitis, in this the acute onset of the weakness is there. Symmetry, compressive myelopathy usually asymmetrical, and non-compressive myelopathy usually symmetrical, like acute transverse myelitis. Bladder vowel involvement seen in early and usually late, or sometimes in acute transverse myelitis in early. तो acute transverse myelitis थोड़ा सा different presentation होता है कि symmetric acute presentation होता है अदर नॉन कंप्रेसिव के कंपैरिजन में, और ब्लैडर वॉवल इन्वॉल्वमेंट अर्ली देखने को मिलता है एक्यूट ट्रांसवर्स माइलिटिस में. तो ये फीचर्स हो गए हाउ टू डिफरेंशिएट बिटवीन द कंप्रेसिव एंड द नॉन कंप्रेसिव माइलोपैथी. नाउ वी डिस्कस अबाउट द कोनस मेडुलरिस एंड द कॉर्डा इक्वाइना सिंड्रोम. सो फर्स्ट डिस्कस अबाउट द एनाटॉमी. So we have alpha L1, L2, L3, L4, L5 vertebra, then sacrum, then coccyx. So we have spinal cord, our spinal cord, and around the level of L1. So this is the bulb-like structure which present at the end of the spinal cord. It is called as conus medullaris. Basically, spinal cord start from the medulla, lower end of medulla, and terminate at the level of L1, and terminal portion is slightly dilated, and this is called as the conus medullaris. After conus, so at level of L1 arise of the S1 to S1 S5 fiber is there. So S1 to S5 roots arise at the level of L1 at the terminal end of the spinal cord at conus medullaris. And L1 to L5 root arise at the level of D12 of the spinal cord. So L1 to L5 root arise at the level of D12, and S1 to S5 root arise at the level of conus medullaris at the level of L1. After this, these are roots that is arises L1, L2, L3, L4, L5, S1, S2, S3, S4, S5. These form a tail-like structure, horse tail-like structure. This is called as cauda equina. This is the tail-like structure which have roots from the L1, L2, L3, L4, L5, S1 to S5, and these root comes out at the level of subsequent vertebra L1, L2, L3, L4, L5, then S1 vertebra, and supplies the our lower limbs. So again, spinal cord starts from the medulla, lower end of medulla, and terminate at the level of L1, where this forms the bulb-like structure which is called as the conus medullaris. At L1, S1 to S5 nerve root arises. Above this, at the level of D12, L1 to L5 root arises. After this, spinal cord ends, and all roots form a hair-like structure which is called as horse tail like structure or chorda equina, and which subsequently comes out from the spinal cord at the different level. So this is the chorda equina, this is the conus medullaris. So after this, so as we see in the diagram, so conus medullaris is present around the L1 level. Below L1 level या below conus medullaris there is a chorda equina like structure is there. So now we how to differentiate between the conus medullaris and the chorda equina. So this is the basically spinal cord. So in conus medullaris there is a involvement of the S1 to S5 fiber is there. So S1 to S5 fiber seen in the involvement of the chorda equina. Sorry, conus medullaris. So sacral anesthesia, yeah, saddle anesthesia, bladder bowel fiber also is in the S1 S2 area. So early bladder bowel involvement, loss of ankle reflex, so saddle anesthesia, early bladder bowel involvement and the loss of ankle reflex seen in the conus medullaris lesion, यानी कि involvement of the cone of the last terminal of the spinal cord. In chorda equina, basically there is an involvement of the root in the chorda equina. So in this there may be the UMN type and element sign both are there, but in chorda equina there is mainly the element sign is there. So involvement of the root, so root pain, asymmetric, so again conus and the chorda equina. This is the cone, this is the so in conus, as I say, involvement of the this area, symmetric involvement, early bladder bowel involvement because involvement of the S1 to S5 fiber, sacral anesthesia, symmetric early bladder bowel involvement, sacral anesthesia, ankle reflex lost, funicular pain may be there. Funicular pain, इसमें आपका root pain. Basically root pain is a sharp shooting pain, electric like pain that radiated along the nerve root. Funicular pain, the diffuse type of pain, lacking localized type of pain. In chorda equina, because there is an involvement of the root. In conus, element plus UMN sign. In chorda equina, lesion is element. Asymmetric onset. Late bladder bowel involvement or no bladder bowel involvement. Sacral sparing may be there. Root pain, this is the classical feature. Asymmetric onset, late bladder bowel, sacral sparing, root pain. These are the features of the chorda equina syndrome. So again, this is a differentiating features like as we say conus medullaris is the lower end of the spinal cord, L1 L2 level पे, nerve root below conus L1 to S2, L1 L2 L3 L4 5 S1 S2. Typical deficit UMN sign below the lesion. In this UMN LMN sign is the mainly the presentation. Spastic weakness, hyperreflexia, pulmonus may be there. Flaccid weakness, hyporeflexia, fasciculation may be there. Asymmetric, symmetric, Babinski sign often positive, Babinski sign absent. Early bladder bowel involvement. Pain usually funicular type of pain, midline back pain, severe radicular pain in the quad equina syndrome. Causes are the tumor, demyelination, infarction. इसमें basically lumbar disc herniation is the most common cause of the quad equina syndrome. Because asymmetric type of lesion. So this is the differentiating features between the quad equina syndrome and the conus medullaris. Now anterior horn cell lesions. So after UMN type of lesion in spinal cord, we come to the element type of lesion. Quad equina is a type of element type of weakness. Then anterior horn cell, classical example is the motor neuron disease. UMN, LMN, both type of sign is there. Atrophy of the muscles, fasciculations, no sensory loss, no bladder bowel involvement, and usually the asymmetric type of involvement is there. So if we discuss anterior horn cell, usually LMN and UMN both sign is there. Atrophy of the muscle is there. Fasciculation, no sensory involvement, pure motor weakness, no bladder bowel involvement or asymmetric onset is present in the anterior horn cell disease. Then neuropathy. In neuropathy, common causes are the diabetes, vitamin B12 deficiency, alcohol neuropathy, and the Guillain-Barré syndrome. In Guillain-Barré syndrome, we may get the long case on this. So, for neuropathy, main the involvement of the distal area. Usually, peripheral neuropathy started with the foot and progressed to the upper limb, progress to the distally, proximally, and then involvement of the upper limb is also there. So, classically neuropathy start distally on onset and then progress to the proximally. But in GBS, proximal weakness is also there at the onset. Usually gradual onset is there. Neuropathy usually progress gradually, either diabetic, vitamin B12, alcohol. But acute onset in the GBS. Sensory symptoms is present, tingling sensation, paresthesia, numbness, other sensation. Ascending type of weakness started from the foot, then ascend upward. LMN sign only, DTR is absent. Sparing of the bladder bowel is present in the neuropathy. So for neuropathy, classical symptoms are the distal onset, gradual onset, sensory symptoms, ascending type, LMN sign, and the sparing of the bladder and the bowel. So for classical example of the neuropathy, for exam case is the GBS. In this, we may have the preceding infection like Campylobacter jejuni. We have history of the diarrhea or the fever, which is usually present before starting of the paraparesis. If there is any fever on the onset of the paraparesis, this is not the GBS. So preceding history of the gastrointestinal infection like Clostridium jejuni, history of vaccination may be seen in the cases of the GBS. Acute onset, ascending type of weakness started from the lower limb, then progress to the upper limb, then progress to the upper limb, then maybe bilateral facial nerve involvement, and maybe the involvement of the bulbar and the respiratory system also. And bladder involvement is usually rare in the GBS and maybe sometimes transiently seen, but that is not a major involvement of the bladder. Then myopathy. In myopathy, we have polymyositis, the inflammatory myopathy group, inflammatory myopathy. We have muscular dystrophy. These are the genetic or hereditary type of neuropathy, and hypokalemia and thyrotoxicosis causes the episodic weakness. Episodic या periodic paralysis. So for myopathy, acute onset, polymyositis may be the cause. For the hypokalemic and thyrotoxicosis, episodic periodic paralysis may be there. And in muscular dystrophy, there is a acute onset never, but gradual onset or slowly progressive muscle weakness is there. So for acute onset polymyositis, for episodic thyrotoxicosis or hypokalemic, and for gradual onset muscular dystrophy. So usually acute onset in the polymyositis, gradual onset in the muscular dystrophy, and the episodic in the hypokalemic and the thyrotoxicosis. Usually myopathy is mainly proximal, distal weakness is usually less, no muscle atrophy is usually, no sensory loss, no bladder wall involvement, DT are usually normal, and plantar is also normal. So for myopathy point of view, onset may be acute, gradual, or the episodic. Proximal involvement is more as compared to distal. No muscle atrophy, no sensory loss, no bladder wall involvement, DTR is normal, and the plantar reflexes is also normal. Now we comes to the case presentation. So till now we discuss where is the lesion, what type of lesion may be there, like spastic paraparesis or flaccid paraparesis. We discuss about the compressive myelopathy, non-compressive myelopathy. In compressive myelopathy, we discuss the extramedullary extradural, extramedullary intradural, and the intradural lesion. In non-compressive, we have various type of lesion. We also discuss from the cortical lesions, then the spinal cord in details. Involvement of the fiber, we discuss the cord syndrome, anterior cord syndrome, posterior cord syndrome, central cord syndrome. We also discussed about the anterior disease, neuropathy, myopathy, and subsequent. So this is the case. Recently we saw the case acute onset weakness in the both lower limb and difficulty in walking since 15 days and difficulty in passing urine since 15 days. So this is a classical presentation of paraparesis, that is the weakness of the both lower limb and the difficulty in passing urine, and involvement of the motor system and the involvement of the bladder bowel system. So for the history point of view, what is important? Basically in paraparesis there are the three system involvement: motor weakness, sensory weakness, and the bladder bowel involvement. So in all complaint, chief complaint, we should ask about the duration, from how many days weakness is there, onset, how is the onset, sudden onset in the vascular lesion, acute onset in the transverse myelitis type, and gradual onset in the compressive type of lesion. So progressive, static, like vascular lesion, weakness may be static after acute onset, but in compressive lesion there is a progressive type of disease, associated symptoms in like fever, any headache, vomiting, any preceding diarrhea for the GBS, any fever for the acute transverse myelitis, any history of vaccination or the preceding infection for vaccination, especially for the GBS, headache, seizure for the cerebral cause, as we see in the cerebral cause, headache or seizure may be there, any history of trauma for the involvement of the spinal cord to the traumatic compression, alcoholic for the alcoholic neuropathy, vegetarian diet for the vitamin B12 deficiencies, fasciculation for the anterior horsal disease, any history of pulmonary TB to rule out the POTS spine. So in history, we should keep in the mind, we should ask for the motor symptoms like weakness. Weakness is started from the distal part or the proximal part. Ascending type of weakness is there, descending type of weakness is there, involvement of the different muscle group, onset, progression, duration, then the sensory symptoms, any tingling, paresthesias, numbness, imbalance on the walking, bladder bowel involvement, difficulty in passing urine or incontinence of the urine. We should ask for the history of these symptoms. In examination, motor system examination is always important. We see for the wasting, for the element type of lesion, weakness, proximal oblique distal. Proximal weakness mainly seen in the myopathies, distal weakness mainly predominant in the neuropathies. How is the grading of the weakness? In element type of lesion, weakness is most severe as compared to UMN type of lesion. Tone, hypertonia, increased tone seen in the UMN type of lesion, decreased tone in the seen in the flaccid type of paralysis. In acute transverse myelitis cases, we may see in the flaccid type of weakness in lower limb. DTR, increase in the UMN type of lesion, increase in the UMN type of lesion, decrease in the element type of lesion, flaccid type of pain. Superficial reflexes, abdominal, especially for the localization of the lesion. If abdominal reflex present above the umbilicus, then and absent below the umbilicus, this may suggest lesion around the T10, the level of the spinal cord. Sensory examination, especially the perianal sensation, especially as I discussed in the quadoequine and chorus medullary differentiation, perianal loss of perianal sensation, cerebellar sign in the Friedreich ataxia and the multiple sclerosis, examination of spine for the any deformity and the tenderness, for the compression myelopathy, for cardiovascular system examination, for cardiomyopathy in the Friedreich ataxia, and skin examination for the neurofibroma. So this is the examination point. Now investigation basically depend on the cause, like MRI spine and MRI brain. If we suspect the cortical lesion, we have features like headache, vomiting, seizure, we may first go for the MRI brain. If there is a lesion around the spine, we find a definitely motor level, sensory level, or the reflex level in examination, then we may directly go to the MRI spine. NCV and EMG for the neuropathy point of view, for the myopathy point of view, or for the interstitial disease point of view. We may go for the CSF if we are suspecting myelitis. In myelitis, common causes are the acute transverse myelitis, neuromyelitis optica, anti-MOG, or the multiple sclerosis. Vitamin B12 deficiency, also look for the subacute combined degeneration of vitamin B12 deficiency neuropathy, and the CPK level for the muscle disease. So this is the small investigation. We may increase our investigation according to the cause we are thinking, according to level we are thinking for the disease. Now, if we make a diagnosis for exam point of view, especially MBBS, MD or DM exam, so after history and the examination, we should make a diagnosis. Diagnosis for the anatomical diagnosis like paraplegia, like weakness in the both lower limb is there. Then where is the lesion? Like localization. Where you localizing the lesion? Like you are localizing in the brain or the spinal cord. If localizing in the spinal cord, what is your motor level, what is your sensory level, and what is your reflex level? If you are localizing to nerve, then which nerve include, which type of nerves include, or muscles, which type of muscular dystrophy or muscle disease is there. So where is the lesion? Then what is the lesion? And what is the pathological diagnosis? Spastic type, flaccid type cause is there, compressive or non-compressive is there. Then last is the why. Why we are the, what is the etiological diagnosis as we discuss in the vitamins. So for etiological diagnosis, V for vascular. For paraparesis, we have anterior spinal cord, anterior spinal artery thrombosis, posterior spinal artery thrombosis, I, infectious, maybe Pors spine, or कोई viral, post-viral myelitis is there, traumatic, or toxin induced. In toxin induced, we have the letharism, kesari dal, which is usually commonly asked in the exam viva. Autoimmune. In autoimmune, we have GBS, 11 type of paraparesis, multiple sclerosis, NMO, neuromyelitis optica, and anti-MOG, antibody disease. So autoimmune, GBS, NMO spectrum disorders, anti-MOG antibody disease, and the multiple sclerosis. For metabolic, we have hypokalemic periodic paralysis and the thyrotoxicosis induced episodic weakness. We may have the iatrogenic, idiopathic, maybe the drug induced, sometimes drug induced neuropathy is there, maybe the idiopathic cause we don't know. In nutritional, we have the vitamin B12 deficiency, which may cause the subacute combined degeneration in the spinal cord involving the posterior column, and maybe the peripheral neuropathy. In syndromic or genetic, we have the Friedreich ataxia and the hereditary spastic paraplegia. So this is the basically why these lesions occur, या paraparesis occur. This is the basically we should keep in the mind for history and the examination and for clinical point of views. Then for management usually may be conservative, maybe surgical, maybe physiotherapy and the rehab. Physiotherapy and rehab required usually in all cases of the paraparesis. Conservative management, if there is a acute transverse myelitis, NMO, acute attack, MS or anti-MOG, usually treatment is the solumedrol or methylprednisolone. methylprednisolone pulse therapy 1 gram per day for the 5 days. If we are suspecting the pars spine, if causes the pars spine after investigation, then the ATT, antitubercular treatment, plus surgery if there is a major compression. For compressive myelopathy, treatment is usually surgical. So basically treatment depends on the cause, what cause is there. If there is a vascularity, if there is a vascular cause, so maybe antiplatelet therapy, anticoagulant therapy. So basically treatment depends on the cause of the lesion. So to summarize, basically we discussed the approach to a paraparesis, which is important for MBBS exam, MD exam and the DM exam. Approach is basically simple, but there is a multiple site of the lesion may be there. Brain, spinal cord, nerve and muscle are the usual site for the paraparesis. Spinal cord is the most important site for the when you approaching the case of paraparesis or paraplegia. Compressive myelopathy, non-compressive myelopathy. In compressive we have extramedullary extradural, extramedullary intradural and the intradural lesion. For non-compressive we have various causes like multiple sclerosis, letharism, SACD according to the different causes, myelitis. So long cases you may get the long case in the MBBS, MD or DM exam, short case in the DM exam. Common cases are the pars spine, acute transverse myelitis, GBS, hereditary spastic paraplegia and the motor neuron disease. Where, what, why? Should be 3 questions in our mind. Where is the lesion, what is the lesion and why this lesion occur. Level, motor level in the paraparesis, sensory level in the paraparesis and the reflex level in the paraparesis. Proper history and examination always the key for making the clinical diagnosis and the localization of the disease. Appropriate investigation and appropriate examination and treatment of the cause. So this is all about the how to approach the paraparesis. So this is all about paraparesis. If you have any question, any doubt about this, you may comment us, you may suggest us. So इसी तरह से कनेक्ट रहिए हमसे, हमारे चैनल को लाइक करिए, वीडियो को शेयर करिए, कमेंट करिए और हमें सब्सक्राइब करिए. थैंक यू.